That's great.
Hi, good morning, Elizabeth.
Are you having any trouble or are you good?
I think I'm good. Can you see my screen and hear me okay?
Yeah, sounds great.
Great, thank you.
hmm
So I just need to wait a couple more minutes before I get started.
Yeah, if you could start right at 10:10, that'd be great. And
Okay.
then if it seems as if you may go over, I will give you a heads up around 10:25.
Okay.
But other than that, you can just do your thing. Thank you for being here.
Yeah, thank you. And thank you so much for all your help in answering all my pesky emails. I appreciate
Yeah,
it.
of course.
Okay, everybody, good morning. I hope you all can hear me. I'm trying to keep an eye on the chat to make sure that you can hear me and see me well, but if you can't, please let me know. We're going to go ahead and get started. My name is Lindsay Yates. I am a student at UNC Chapel Hill, and this morning I'm going to be sharing with you a little bit about one state-funded maternal and child health program's efforts to move towards reproductive justice. So by the end of our time today, my goal is to help you all understand the purpose and structure of the Improving Community Outcomes for Maternal and Child Health program here in North Carolina, to better recognize the principles of reproductive justice, and to identify successes and important steps in incorporating this reproductive justice framework into existing maternal child health programs. And before I get started, I also just want to thank my co-author and mentor, Dorothy Salenti, for being here today. At the end of the presentation, we will have made some time for questions. So I will be answering questions, but I also thank Dorothy in advance for answering questions also since she's joining us. So preterm birth, which is defined as a baby born at less than 37 weeks, and low birth weight, which is defined as a baby weighing less than 2,500 grams at birth, are among the leading causes of infant mortality in the United States. These outcomes, which have important consequences for families and are associated with increased cost, are also well documented racial disparities. To address these adverse birth outcomes and disparities, the North Carolina General Assembly legislated funding to invest in evidence-based programs shown to reduce infant mortality and improve birth and health outcomes for children. In fiscal year 2016, North Carolina launched the Improving Community Outcomes for Maternal and Child Health program, affectionately known as ICO for MCH. This program uses a collective impact framework, implementation science, and a health equity lens, providing local health departments with resources and infrastructure to address certain aims of improving child health. 5 local health departments, which I'll continue from now on to refer to as sites, were awarded funding, and these sites covered 14 counties across the state. The ICO for MCH program was designed to address 3 overarching aims: improve birth outcomes, reduce infant mortality, and improve the health of children ages 0 to 5 years old. To address aim 1, all sites were required to implement an evidence-based strategy focused on increasing access to long-acting reversible contraception, or LARC. This evidence-based strategy focused on ensuring that individuals of childbearing age could access LARC in their communities if and when they desired. Long-acting reversible contraception, or LARC, both intrauterine devices and implants, are recognized as highly effective forms of contraception. LARC offers a number of benefits. In addition to it being a highly effective method, it is also safe for most people. It's the set it and forget it method, meaning that these methods are not user dependent, and these methods can be used for several years at a time. A number of events drove increasing excitement about LARC, and I just want to highlight a few of them. One was the Contraceptive Choice Project, which demonstrated that increased use of LARC was associated with a reduction in unintended and teen pregnancies compared to use of other short-acting contraceptive methods. Because unintended and teen pregnancies have been found to be associated with increased risk of adverse birth outcomes like preterm birth and low birth weight, LARC represented a potential solution to these ills. In addition to reducing the number of unintended and teen pregnancies, findings from the Choice Project and the Colorado Family Initiative highlighted that LARC use increases when individuals have access to these methods at low or no cost. With such evidence, the American College of Obstetricians and Gynecologists, or ACOG, published a committee opinion urging for an increase in access to contraceptive implants and intrauterine devices to reduce unintended pregnancy. The Association of State and Territorial Health Organizations created a learning collaborative, or several learning collaboratives, for state and territorial health departments to support those agencies in developing and sharing best practices aimed at improving access to LARC. Finally, beginning in 2012, the Affordable Care Act required that non-grandfathered insurance plans covered FDA-approved birth control methods such as LARC, which led to reductions in cost sharing and increased access to birth control methods like LARC, implants and intrauterine devices. So these events were happening consecutively and sometimes concurrently, and all of these things happening drove a call for an increased access to LARC. But as the call to increase access to LARC grew, a cohort of family planning providers and advocates tempered excitement about increasing access to this contraceptive method. And they encouraged a thoughtful integration of LARC with a primary focus on reproductive justice. Reproductive justice is a concept coined in 1994 by a collective of Black women committed to advancing reproductive rights and social justice. Reproductive justice, as defined by Sister Song Women of Color Reproductive Justice Collection, is the right to maintain bodily autonomy, the right to decide when to have and not have children, and the right to parent children how you desire. In applying the reproductive justice framework to a strategy aimed at increasing access to LARC, stakeholders noted some important issues. First, reproductive justice challenges the perception of LARC as a solution to adverse birth outcomes. The reproductive health community embraced LARC as a strategy to counter pregnancies that may lead to worse health outcomes for children and mothers. LARC has also been proposed as a method to reduce racial disparities in those outcomes. Reproductive justice posits that disparities in reproductive health outcomes are rooted in systematic racism and other forms of oppression. By not acknowledging the racist and inequitable settings that contribute to these outcomes, a LARC-focused strategy is insufficient. Second, reproductive justice seeks to ensure that people have access to the reproductive services that they want. Although some individuals may desire LARC, a primary focus on this method without ensuring access to other methods or services feels reminiscent to reproductive injustices of the past, specifically the coerced and forced sterilizations of thousands of people, 7,000 in North Carolina alone. The impact of this history remains in the collective memory of historically marginalized communities that disproportionately experience sterilizations, including Black and Indigenous people. Lastly, reproductive justice requires that individuals have autonomy, including the choice to have LARC devices removed when they want. When a LARC device no longer meets an individual's needs, it should be removed without consequence or shame. The primary focus on LARC insertion instead of LARC services is in part the result of excitement from the reproductive health community focused on increasing LARC users. An evidence-based strategy that is focused on increasing access to LARC must also include increasing access to LARC removal. So in fiscal year 2017, one ICO for MCH site expressed concerns about implementing a strategy aimed at increasing access to LARC to improve birth outcomes. Local advocates in the community felt that focusing on LARC would create actual or perceived reproductive coercion. They recommended a strategy more focused on reproductive life planning and informed consent. The site shared local concerns with state stakeholders and who researched options and recommended the reproductive justice framework as a revision to this evidence-based strategy. To address concerns of reproductive coercion, ICO for MCH leaders consulted reproductive justice organizations to educate all ICO for MCH staff about reproductive oppression and intersectionality, and to inform the implementation of a modified evidence-based strategy. In adopting a reproductive justice lens, ICO for MCH leaders and staff participated in reproductive justice trainings and reframed the short-term performance measures to be monitored and assessed. Each of the 5 sites adopted new actions to incorporate reproductive justice into their work. Sites made modifications over a 2-year time period, and although sites made changes based on the context of their communities, the teams tended to focus their efforts in 3 specific ways, which I'll go over. First, sites hosted or supported reproductive justice trainings for local staff, clinicians, and community stakeholders. The purpose of these sessions was to help orient individuals to the reproductive justice framework. The trainings were led by facilitators skilled in reproductive justice, including Sister Song and Sister Beach. Over that 2-year time span, more than 400 local health department and non-local health department providers were trained in the reproductive justice framework and counseling approaches relevant to reproductive life planning. Second, sites focused or worked to ensure that language used to describe family planning services incorporated reproductive justice principles. Materials and presentations focused on patient choice and reproductive life planning, as opposed to focusing only on the effectiveness of LARC or using a tiered approach to contraception counseling. Lastly, sites have considered other reproductive justice measures. As part of the ICO for MCH program, sites needed ongoing access to data to improve strategy implementation. The evaluation team uses electronic medical record data and other public databases to provide this information, but the data does not provide robust reproductive justice measures. Sites recognizing this gap sought to measure reproductive justice in meaningful ways in their communities. This includes surveying patients about their reproductive health plans and needs, or hosting focus groups centered on these topics. Using the reproductive justice framework to improve reproductive health services is critical, and we have gained some valuable insight into incorporating reproductive justice into a state-funded maternal and child health program. Although we recognize there is more work to be done, we have learned some valuable lessons. One of the lessons learned was the importance of seeking and valuing feedback from various community stakeholders. It is critical to build and deliver interventions in partnership with individuals with lived experience. Their insight challenges our acceptance of LARC as the best strategy to improve birth outcomes. Another lesson learned was the importance of emphasizing reproductive justice in our measurements. What we measure matters. Updating performance measures that signal success enables sites to shift their efforts and activities to more meaningfully reflect reproductive justice. This begins with learning from and partnering with organizations at the helm of the reproductive justice movement. Trainings and consultations with these leaders helped us to synthesize reproductive justice principles and apply them to this work. As we continue incorporating reproductive justice in our work, we recognize that there is more to be done, but want to show that there are some steps programs can take to begin moving towards reproductive justice. With growing evidence and support for increased access to LARC initiatives have to be coupled with more robust reproductive justice efforts. In recent years, maternal and child health providers and advocates have assumed the charge from Black and Indigenous people to adopt reproductive justice in their maternal and child health initiatives. They've highlighted the importance of applying this framework to family planning services in light of systemic and historical harms. As healthcare, public health, and social service agencies recognize the relevance of reproductive justice, finding ways to meaningfully incorporate this framework into existing systems of care is growing more relevant. This is especially true during a time when local agencies are charged with assuring the health of the community and are under increasing pressure to improve adverse health outcomes and remain fiscally responsible. We encourage programs to take some of these first steps in their work and center reproductive justice in their reproductive health services. Again, I just want to thank my co-authors and the ICO for MCH staff and leadership for their support. I also want to thank you all for attending the session today, and I welcome any questions or comments at this time. Thank you, Lynn. Thank you, Dorothy.
Thank you. That was great.
Thank you, Angelique. Thank you, Amy. Thank you, Cheryl. Yeah, Dorothy mentioned our partnership, or ICO for MCH's partnership with Upstream. So a number of our sites are working with Upstream, which is an organization that has partnered with a number of different states in the US, North Carolina being one of the more recent partnerships. Some of their work includes increasing access to LARC as well as other contraceptive methods. They also recognize the importance of reproductive justice and a focus on health equity, which is something that we have done. Thanks, Deepa. So Deepa is here from Upstream and can talk more about it. But some of our sites have partnered with Upstream to ensure that the reproductive health services that they are making available are really broad and not just solely focused on LARC, but also focused on broader reproductive health or family planning services in the state. So we're glad to have Upstream as a partner with some of our sites, and they've been really great to work with. And I don't know the details, and I don't want to say more than I should, but I think that if there are health departments or agencies that are interested in partnering with Upstream, the last, I think, conversation that we had, which was several months ago, Upstream did have opportunities for other partnerships. So if you are interested in partnering with them, they have some great analytic tools and data resources. They have some great opportunities to really get feedback from them. I don't want to give away all of the details because I can't recall them right now, but yes, please contact Deepa if you're interested in thinking about family planning and thinking about also how you can center reproductive justice, because that is something that they are focused on. Okay, there was a comment from Evan, and I'll just read it out loud. If we intentionally unpacking white supremacy, it begins with an analysis of what is promoted as evidence-based care. Advocating for what healthcare knows best is fundamentally flawed and unjust. The recent focus on preconception health has seemed to focus on pushing LARC and limiting conversations to pregnancy and not the whole person. Thank you for your provocative presentation. Yes, thank you so much, Evan. I think I I'm glad that we realized that. I think that really came from, again, the community and us being willing to listen to the community and have folks that push for the change, and us thinking about what it meant to provide family planning and family planning services, and to think more deeply about the impacts of the history in our state around eugenics, as well as some of the challenges that we were seeing with, I think, a large evidence-based strategy in other states, and thinking about how we could pivot to more better focus on equity, which is something that is key in ICO for MCH, is applying an equity lens, and the reproductive justice framework really fit well within that focus for us. So yes, I agree. Thank you so much for your comment. I was trying to see if there were any more comments. Okay, great. Deepa included some great information about Upstream. So yes, reach out to them. Thank you all again for presenting, and please feel free to contact me or our co-authors or any of the folks from our team if you're interested in learning more about ICO for MCH and the reproductive justice and health equity work that we're doing. Thank you, and everybody enjoy the rest of NCPHA.
Thank you, Lindsay.
Thanks, Elizabeth. Thanks, Magla. I hope I pronounced it right. I'm sorry if I did not. Thank you, everyone, for attending today. I'm going to stop sharing, but I'll stick around in the room in case there's anybody that has any other questions.